Ladies and gentlemen, dear colleagues, it is a pleasure to be with you today and to present my presentation on how to classify cutaneous manifestations of drug hypersensitivity. This is the second recording. In the first recording, there were technical issues, so I'm more than glad that I can present some data on drug hypersensitivity and hope you have a great Congress. Let us start with a typical case report to make the point. Imagine a patient who took amoxicillin for tonsillitis over 7 days, and 1 day after stop of the therapy, she developed itching skin lesions on the trunk, which were spreading. In this example, she had no fever, the full blood count was okay, and differential C-reactive protein and liver enzymes were slightly elevated, but not more than 1.5 times the normal value. She was hospitalized in Germany, as is typical, and received topical and systemic corticosteroids and antihistamines, and showed a fast improvement afterwards. Here are the clinical pictures of such a patient, as you can see. And now is a question, if you have got a patient with drug hypersensitivity, how do you classify? And that is not always easy because there are different levels, dimensions of classification, and each of these levels or dimensions has got its meaning and some value to it. The mechanism, and here I would like just to show it at the last stop, is not very useful in the beginning because you know the mechanism only at the end after you have made your allergy diagnostics and not before. However, you have got from the history information on the elicitor, which is very important because this has to be avoided. You get the information either by history or even by clinical pictures on the manifestation and morphology. And you can try to find out the primary manifestations in the skin and the lesions, as well as their evolution. And these are associated with risk and severity. You get some indications on the severity, which indicates a danger for the patient upon re-exposition. And also very important is the chronology, the time interval between the intake of the drug and the manifestations, because this gives you an indication about the possible mechanisms involved. And you want to ask also for the duration of the total intake of the drug versus the until the reaction occurred versus the interval from the last intake. Let us go through all these points. For that, I just take the history of the patient again. And here you find some information already. And this is a typical history which you also will receive. Amoxicillin 1 day afterwards, after 7 days, skin lesions, and a slight elevation of liver enzymes and of inflammation. So for the elicitor, you can see that you have got the suspicion of amoxicillin hypersensitivity. This also gives you more information because you know that in amoxicillin hypersensitivity, you mostly have got a limited allergy to the aminopenicillin side chain, and very rarely only to the beta-lactam moiety, so that a pan-beta-lactam allergy, although it's not impossible, it is really not probable. In terms of manifestation and morphology, you find an exanthem. The question is, what is an exanthem? An exanthem comes from the Greek exantheo, which means blooming up. And it is a skin reaction which occurs suddenly, blooming up, and is widespread over the body. So at the moment, we do understand an exanthem as an acute widespread eruption of multiple small round to oval erythematous macules and or papules with different degrees of confluence. What we typically understand as an exanthem are the childhood diseases like measles or varicella. And then you keep in mind to describe the skin lesions as good as possible using the common primary skin lesion nomenclature in dermatology. Here you have got the different primary lesions, which I'm not going into too detailed, like a wheal, which is temporarily only, a macule, papule, pustule, vesicle, or bulla, or an angioedema, which is a deeper wheal, actually. Sometimes it can be difficult to decide if there's an urticaria to a drug or maculopapular exanthem, as these maculopapular exanthems might look urticarial, edematous at the beginning. However, in this case, you can circle the individual lesions, and you see an urtica is going away at that spot of the individual lesion and may return somewhere else, whereas the maculopapular edematous lesion of a beginning maculopapular exanthem is staying at the same site. And now you have to give the manifestation, which is important, of cutaneous drug hypersensitivity reactions. Concerning manifestations, you differentiate between localized, Vortrag geht nicht taub, between localized reactions, which we are not going to talk about now, and disseminated or generalized reactions, which have to be further differentiated. In disseminated or generalized reactions, you might have either urticaria, wheals and or angioedema or exanthems. And if you have got wheals, you have got you can also have an association with the wheals or angioedema. You can also have anaphylaxis. Concerning exanthems, and let me highlight this for you, you normally have in more than 90% of the patients, you have got a maculopapular exanthem. However, to be able to recognize untypical exanthems, different from maculopapular exanthems, you have to look very closely at the primary lesions of these exanthems. There are exanthems which occur with blisters, and this is a warning sign, because if you have got blisters on the skin and in the mucous membranes, and the patient is quite ill and might have a confluent erythema with targetoid lesion, it's a severe cutaneous adverse reaction. It's Stevens-Johnson syndrome, and even if it is, and if it is even larger, having more than 30% of the body surface, is a toxic epidermal necrolysis, and this is feared. On the other hand, blisters can also refer to a generalized fixed drug eruption. In this case, patients are systemically well, the mucous membranes are not involved, and you have got multiple oval erythematous patches with central bullae. This is a differential diagnosis. So you check if you have got blisters. You check if you have pustules, because if you have pustules, you might have an acute generalized exanthematous pustulosis, which is characterized by widespread erythema, neutrophilia, fever, sometimes slight liver enzyme increase, and pustules, small pinpoint pustules on the erythemas. You might have purpura, and then it is a vasculitis, and it's a different disease, although drugs, I have to say, are extremely rarely the elicitors for vasculitis. Normally it's the infection and not the drugs, which is a culprit. And then you might have only macules or papules, which may have a different pattern, which if you have got a specific pattern, if you have got a non-cutaneous organ involvement, you might have a drug reaction with eosinophilia and systemic symptoms. In this case, you have got an organ involvement like liver involvement. In our case, example case, you have got just a slight elevation that does not qualify. For DRESS, you need some criteria, often eosinophilia, often atypical lymphocytes. You have got an increase of liver enzymes at least twice the normal value, at least twice measured in different time points. And it is a severe reaction, often edematous skin reaction in the face. This has specific criteria to be fulfilled. If you have got a normal maculopapular exanthem, which is in atypical places, in this case, flexural intertriginous places, then you have got a systemic drug-related intertriginous and flexural exanthem. And if you don't have these specific features, you have got the typical one, the maculopapular exanthem, which occurs in the majority of the patients. So how is the description of the exanthem in our example patient? You best describe not only the primary lesions, but also the distribution. The distribution may be localized, just one arm, for example, or disseminated, widespread over many parts of the body, or generalized if it involves all the body. Here, in this case, I would say might be disseminated or perhaps even generalized. And then you look at the lesions, you see urticaria-like atypical targetoid lesions with a gray center, a little bit roundish here, a maculopapula with atypical target lesions. However, these are a subdistinction of a maculopapular exanthem. So one would say it's a disseminated maculopapular exanthem with targetoid appearance. So this is a manifestation and morphology. You have got some systemic involvement, but not very much. And in this case, you don't have the criteria for DRESS. Severity sometimes help you just to understand how is the risk for the patient the next time. There's a moderate severity here. She was hospitalized, but it was not life-threatening. Hospitalization is more often done in Germany than in some other countries. Now we come to the chronology. Chronology gives you a lot of information, but it should not be the only information you get. The chronology is important because it gives you some indication about the clinical manifestation. In drug hypersensitivity, you normally have got reactions which occur in the first hour, immediate, up to 6 hours after the intake of the drug. And then you have got urticaria and anaphylaxis. It's called an immediate hypersensitivity reaction. On the other hand, you can have exanthems with a delayed occurrence. They never occur within the first 6 hours, never. But they, if there is an allergy already and pre-sensitized patients, they may occur several hours after the intake. But in patients who need a sensitization phase, who are not sensitized before, it often takes 1 week or even 2 weeks to develop the exanthem. And this gives you a lot of information because alone the chronology gives you common associations which are interesting. With the immediate chronology, you, as I said, you have reactions which occur up to 1 hour or 6 hours after the last drug intake. And if the drug is given IV, it occurs much earlier than if it is given non-systemically per oral. And this information gives you an indicator for clinical manifestation. It's not enough time to make infiltration of other cells, but it's enough time to degranulate mast cells. So you may develop urticaria, angioedema, bronchospasm, or anaphylaxis. It is an indicator for effector cells because so fast only mast cells and basophils are able to react. So it's an indirect indicator for a potential mechanism which is associated with severity. It may be, and you cannot tell which is true, an IgE-mediated anaphylaxis or urticaria type 1. It may be non-allergic, like a non-steroidal anti-inflammatory drug hypersensitivity. It may be, and this is not well studied, perhaps even an IgE immune complex anaphylaxis. On the other hand, if you have got a case with non-immediate delayed occurrence, like in our example case, you also can learn from it. The delayed chronology is typical from 6 hours to several days. It also is an indicator for maculopapular exanthems or other exanthems. It's an indicator for the effector cells, which in drug hypersensitivity are T lymphocytes. Sometimes other cells are involved secondarily. And it's an indicator for the mechanism. It's a T cell mediated and orchestrated cytotoxicity or inflammation, which is the case in this chronology. The advantages of a chronological approach are that you get a time window, which can help you to indicate the responsible drug if a patient has taken several drugs. You know that if the drug is the elicitor of a reaction for urticaria, asthma, and anaphylaxis, it has had to be taken within 1 hour, and rare cases up to 6 hours. Here it said 12 hours after exposure. Maculopapular drug eruptions occur 4 to 14 days after start of the use. AJAP can be very fast if for aminopenicillins. For other drugs, it's similar to maculopapular drug eruptions. Stevens-Johnson and toxic epidermal necrolysis have a little bit longer time window than a common maculopapular drug eruption, and DRESS has the longest time window for starting of the reaction, like for anti-epileptic drugs. It has to be mentioned, however, that if you have got repeat reactions, you're already sensitized, and the start of the reaction is considerably shorter, even some hours for the exanthem, possibly after the last intake of the reaction. You also have to be cautious not to only use the chronological approach. Like you say, it's a non-immediate reaction, it's an immediate reaction, and thinking that the mechanism would be clear. You just use it as a chronological information and not more. It may not be precise if it's based on the patient's history alone, so you always have to be cautious, and you also have look at the dynamic process. So you should not use it for classification without further information. You should use it as one means for classification and not the only mean of classification. And you shouldn't use it for uncritical information about the mechanism, because if it is fastly occurring, it's not always type 1 hypersensitivity. So you should use it together with all the other information. Now we come to the classification of the case. Here, in this case, I presented to you, we have got information, very important information about the elicitor. You have got a suspicion of amoxicillin hypersensitivity and of a pan-aminopenicillin allergy. You have got a generalized or disseminated maculopapular targeted exanthem with a little in systemic involvement, not classifying for DRESS. You had moderate severity, and you have got a chronology of non-immediate hypersensitivity reaction. The mechanism is something which you don't know at the moment in this patient. You need first to do tests. The mechanism, as I have already indicated before, is mostly in drug hypersensitivity reactions in about 95 to 99% of all cases. immediate type hypersensitivity reaction, which is normally acute, as I have told you, according to the chronology, or a delayed hypersensitivity reaction with T lymphocytes with a late occurrence. So in terms of the mechanism, this is only known after the test. If you have got a positive skin test, patch test, or delayed reading of intradermal test, in this patient, you would have a type 4 reaction. If this would not be the case, you would describe it as a non-allergic T-cell mediated hypersensitivity reaction. So in this example, you could issue a medical certification after the reaction has taken place, before the allergy workup is finished. You give the information about the patient. You give information what may happen. It's a potential life-threatening drug hypersensitivity. In this case, it is potentially life-threatening is relative, because what can happen is a typical maculopapular exanthem, not more. And it has reacted with, and then you give the manifestation, maculopapular exanthema, mild elevation of liver enzymes, in temporal relationship with oral administration of amoxicillin. The above listed medication and all beta-lactam antibiotics are to be avoided until the reaction has been fully investigated, and then you can give your contact details and signature. This would suffice until you make your investigation, and then you can make a proper workup and issue an allergy pass. Finally, the question is, why is classification for drug hypersensitivity so important? It gives you an exact description for one patient, and it enables you to give an exact diagnosis and therapy. It is very important, and that is highlighted, that for making a good test plan, what test are you going to do, patch test or intradermal test, immediate or delayed reading? This is given by the classification and by the history. It is important that you classify your patient for studies correctly, and that you use always the standardized procedures and standardized phenotypes when you pool patients in multi-center studies. So coming to the end of the talk, the take-home messages are that a common classification for drug hypersensitivity is needed. It's not so complicated, but it is important to understand it. There are different ways to classify, which are in parallel and which complement each other. So you give information about the elicitor, about the manifestation and morphology, about the chronology, sometimes about the severity, and in the end, about the mechanism. Of those, the elicitor, to avoid, and the manifestation as a severity parameter are most important. This is important information for probability assessment and the risk of the patient. And it's important that reliability beats quantity of the information. With that, I would like to end my talk. I thank you very much for your attention. I'm very happy that I can be with you, although over many hundred and thousand kilometers and via online. And I wish you a great Congress and a lot of information that you gain anew. Bye-bye.